Welcome back to the UNC OBGYN Quality Improvement Toolbox Lecture Series. Today we're going to be talking about PDSA cycles. Recall the Institute for Healthcare Improvement model for improvement, which we've seen in previous lectures. All of the tools we've learned up until now have been designed to answer the three questions that you must ask as part of any improvement project. The PDSA cycle itself is a tool for enacting change in an environment that doubts change. We're going to document each PDSA cycle and in that way preserve the knowledge gained from each cycle, which is critical in a fluctuating clinical environment where teams change, yet you want improvement to continue. Anytime you try to make a change, you're going to have doubters, skeptics. The PDSA cycle helps give you answers to some of the most commonly raised doubts or questions about an improvement project. Is change really needed? Is change even possible or affordable? How do you know that your hypothesis about this problem is correct? And even if we make a change, how can we maintain enthusiasm to make sure that those changes continue? As part of a PDSA cycle, to answer the question, is change needed, we're going to gather preliminary data to prove your case that improvement really is necessary. When asked, is change possible or affordable, we're going to offer an installment plan for change, if you will. In other words, we're going to make small changes along the way and incrementally improve towards our goal. Towards the question of whether the hypothesis we put forward is correct, we're going to test many small hypotheses before implementing any large-scale change. And then again, when we start to implement change, do so on a small scale to prove that it works before rolling it out to a larger scale. And finally, with regards to enthusiasm and maintaining it over a long term, you'll be amazed at how easy that is when you progress in a stepwise fashion and win small victories along the way. It will reinvigorate your team and continue your improvement. PDSA stands for Plan, Do, Study, and Act, the 4 steps of a PDSA cycle. And remember, each cycle is one small incremental step towards making change. I love the idea of rolling a wheel up a long hill. You don't get to the top of the hill in one giant leap. You get there gradually over time. PDSA cycles are also a little bit of a different scope from the other tools we've been using so far in this lecture series. The tools we've studied so far are useful for managing a project long term and over a longer period of time. Each PDSA cycle, on the other hand, focuses on a much narrower scope within that project. Each cycle is one attempt to make a small bit of improvement, and those cycles build on one another such that over time you get a great amount of improvement. And you're going to use all of the tools that we've learned so far in planning and executing your PDSA cycles. As with many things in life, with PDSA cycles, 80% of the work, if not more, is in planning. We're going to do several things at each cycle during our projects. It's always helpful when you start a PDSA cycle to start by reviewing your aim, particularly your aim statement that you made. Then, for each cycle, we're going to declare a strategy for that cycle, and based on the strategy we declare, identify what data we need to collect, and then figure out how we're going to fulfill our data needs or collect that data. And finally, we're going to state a concrete hypothesis about each piece of data that we're collecting, and that helps to focus us and keep our project in perspective. Now we're going to walk through our sample case to see how they designed and implemented the first PDSA cycle in the Mickey VAP project. Looking back at the driver diagram for the project, you'll recall that the team designated the 5 elements in red as essential components of what they called a ventilator bundle for preventing ventilator-associated pneumonias. In planning the first PDSA cycle, they looked back at their process map and decided to address one particular part of the ventilator bundle, oral care, as this was an easy-to-address, straightforward, concrete thing that could be addressed quickly. Once the team decided to address oral care, they looked back at their fishbone diagram at all the different areas that addressed oral care. And specifically, because we're looking for concrete, actionable parts of our fishbone diagram, we're looking at some of the finer bones because these are the more concrete problems that we identified. For instance, as part of a process issue, they asked the question, why isn't oral care happening as often as it should? In other words, why is it being inconsistently implemented? They also looked at the people aspect of the problem, asking the question, maybe physicians have over-delegated oral care and divested themselves of their responsibility of providing it. And maybe there hasn't been good collaboration between different parts of the care team to ensure that oral care is provided. Again, they are looking at the finer bones of the fishbone diagram for concrete, actionable problems. So then, based on these things that they identified from their fishbone diagram, they declare a strategy, or a couple of strategies really. They postulated that they could improve oral hygiene and therefore lower the ventilator-associated pneumonia rate if they engaged physicians in evaluating the oral care that was happening every day during the daily rounds that were already happening. If they made it such that oral care could occur more frequently by making it easier and faster for people to provide, and ensuring that the respiratory therapist doesn't bear sole responsibility for making it happen. In other words, making sure that there's a system of backups so there's always multiple people responsible for providing it. The next step is to turn those strategies into specific questions that we can answer in a concrete way and that we can start gathering baseline data on. So for those strategies, they decided to make their questions: are physicians regularly reviewing oral care? How often do the respiratory therapists perform oral care? How long does it take them to provide the oral care? And do the nurses ever participate in performing oral care? The team then came up with a preliminary way of answering each of those questions. To figure out if the doctors were involved in reviewing oral care, they thought they could review doctors' progress notes to see if oral care was addressed. To figure out how often oral care was performed, they thought they could observe and count the frequency of how many times oral care was provided per patient per day to get an average. And then to look at how long it takes, they planned to observe respiratory therapists and nurses providing oral care and time how long it takes them. But wait a minute. Those are going to be very time and manpower intensive pieces of data to try to gather. If you're thinking about observing individual patients for shifts or parts of shifts at a time to count the number of times oral care is performed, that means a person's going to have to sit in the room with an individual patient, and you can only gather data on one patient at a time. Similarly, if you're going to walk around observing RTs and RNs performing oral care and timing them, you can only observe one of them at a time, and it's going to take you a long time and a lot of man-hours to gather that data. Similarly with chart review, that takes a long time. That data plan is much too complicated and time-consuming. You need to be realistic with the kind of data that you want to gather and how you're going to gather it. It's helpful to remember in a QI project that QI is not a randomized controlled trial. You don't need statistically significant data necessarily to act on it. And often, statistically significant data is old data, not actionable data. You need data that is quick to gather so that it can be quick to act on, because PDSA cycles are supposed to be rapid, acting on timely data and yielding quick improvements. So let's try again. Let's take a step back and try to figure out exactly what the core of the question is we're trying to ask. What concept are we trying to get at with each one of those questions? In other words, what we're really trying to get at with all of those questions is what things make it more difficult for the team to conduct oral care more frequently. And let's think again about how to gather data about it. To figure out if the doctors are regularly reviewing the oral care that's happening, why don't we just ask them? What do they do to review it? What do they do to manage oral care? As far as how often it's performed, we're going to come back to this one in a second, but there's a way that we can get some objective data about how often that's happening. As far as the things that make it difficult to perform, let's just ask the respiratory therapist what makes it hard. And as far as if the RNs are participating or not, well, we're going to ask the respiratory therapist one thing. Let's ask them about whether or not the RNs are participating too. This is going to be much faster data to gather. And don't necessarily turn your nose up at surveys as part of a project like this, because one advantage that they provide is that by asking the members of the team about the work that they do, sometimes that can help you get buy-in from those different parts of the team. Rather than just sitting there observing them doing their jobs and making them feel judged, you're trying to involve them in improving the care that they provide. Now let's just look specifically at trying to figure out how often oral care is performed. So now back to figuring out how many times oral care is being provided per patient per day. Well, all we care about is the average, right? So all we need to know is how many of the supplies were used each day divided by how many total intubated patients were there, and that should tell us how often oral care is being provided per patient per day. So then the team tried to plan how are we going to get that data, how are we physically going to find those numbers. Well, to find the number of intubated patients per day, they decided that they could just look at the census or even just walk through the unit at the beginning of a shift, 7 a.m., and then do the same thing at the end of the shift. Take the number of patients intubated in the morning, the number of patients intubated in the evening, take the average of those two, and there's your average number of patients intubated that day. Then they could count all of the oral hygiene kits in all of the different places where those things are kept, both in the morning and then again in the evening, and figure out how many were used throughout the day. Taking those two numbers and dividing, you get an average for how many times oral care should be provided per patient per day, and that's exactly the number that you're looking for. Then they tried to come up with some questions that they could ask the respiratory therapists as part of a survey to figure out what makes it hard to do their job. So the things they brainstormed were to ask how many times do they aim to do oral hygiene each day, what things make it difficult to achieve that goal, what things slow down providing oral care, asking if it took less time to provide oral hygiene, would they do it more often, and then what other things might they prioritize first that then get in the way of performing oral hygiene as frequently as they want. But here again, there's a little bit of a problem with asking all of those questions. People very quickly get survey fatigue, and the longer a survey is, the less likely people are to actually complete it. One strong piece of advice that I would give when designing surveys is try to ask fewer questions so that you can get more answers. So let's try again. What about instead asking the RTs, how often do they aim to provide oral care? Just an open-ended question about what makes it difficult to achieve that goal. And then taking a little bit of the burden off and just saying, in a hypothetical world where you had more time to get everything that you wanted to done, where would you prioritize oral care among those many other tasks? Just to get a sense of how important they see it as. The team also thought they could get another perspective from the nurses and ask them in a survey, from their observation of the respiratory therapists, how could oral hygiene be completed more effectively? And ask them straight out if they do oral hygiene when they notice that it needs to be performed. But another caveat, the way those questions are framed, it's almost asking the nurses to tattle on particular respiratory therapists that they feel like aren't doing their job or aren't providing oral hygiene as often as they should be performing it. And I think a good phrase to remember here is that by digging in dirt, you won't find truffles. In other words, let's try to ask those questions in a way that's not pointing fingers at anyone so that we avoid a culture of blame in our quality improvement. Instead, what if we ask the nurses, how do you manage oral care for intubated patients, for your own patients? And then, when a patient has not received oral care, why do you think that might not have happened? So instead of particularly asking them to point out faults in the respiratory therapists, we're leaving those questions a little more open-ended. Okay, so let's go back and summarize how we are going to address each of these pieces of data that we need. As far as figuring out the physician's involvement in oral care, we're going to have a survey. We're going to ask, say, 5 physicians how they provide oral care to patients and how they then follow up on whether oral care is being provided. To figure out how often it's being done, we're going to count the number of oral care kits at the beginning of a shift minus the number left at the end of the shift and divide that by the average number of patients on the census that day they're intubated. And for comparison, we can look at how many times the respiratory therapists say that they ideally would perform oral care in the survey we're going to ask them. So as far as surveying the respiratory therapists, we're going to ask them how often they aim to provide that care, what things make it difficult to do, and how do they prioritize oral care among the other things that they have to do. And then for the nurses, we're going to ask them, how do they manage their patients' oral care? And when they see that it hasn't been performed, what things do they think stand in the way of that happening? Finally, before we actually gather this data, it's important to state a concrete hypothesis about each of these questions so that we have something to compare our answers to. So the team postulated that with regards to MD review, they thought that probably after the initial orders were written for oral care, probably less than 10% of the time physicians were actually following up to see if it was happening. As far as how often it was happening, they guessed that the RTs would try to provide oral care maybe 6 times per patient per day, but that because they were prioritizing other things more frequently, maybe that it would only be happening 5 times per day per intubated patient, so a little bit less than the goal. As far as what makes it difficult, they thought that maybe the RTs and the RNs would identify that gathering supplies to do oral care was something that stood in the way, and that the nurses, in their observations, would observe that when it happened, oral care was being provided very well and very thoroughly, but that it wasn't happening as often as it should. And as far as RNs participating, they postulated that the nurses were probably more often delegating to the RTs that job of oral care rather than performing it themselves. To help your team so that you don't have to reinvent the wheel when planning your PDSA cycle, I provided blank planning templates in the link after you complete the lecture, where you can fill in the strategy that you're trying to address, what question you're asking about that strategy, what the answer is that you're looking for, how you're going to find that data, and then your hypothesis about what the data is going to show when you gather it. Again, these are going to be available in a link at the end of the lecture. So now we finally get to the do part of our PDSA cycle. And the key is that we're going to do all of these things on a very small scale first. We're not going to try to survey every single doctor in the hospital about these things. We're going to start with a very small set of them. Again, PDSA cycles do not require a sufficient data set to publish. You don't have to have a p-value of less than 0.05. You just need enough data to have something actionable that you can act on so that you're basing your changes that you're going to implement on observation, not just on wild conjecture. This is an example of the tool the team used to gather data about particularly the number of times oral care was being provided per patient per day. We're going to come back to in a later lecture tools for data gathering, but as you can see, it's very simple. They just in the morning counted the number of intubated patients, in the evening counted the number, and then averaged those two to get the number of intubated patients for the day. And then the same thing for the respiratory care kits. They counted the number in the morning and all the different places where they're stored, counted the number in the evening, and subtracted those numbers to get the total number used throughout the day. So now we have planned our first PDSA cycle. We have done our data collection. Now it's time for the S, studying the data we've collected. So when the team looked at the data they collected for a week, they found that on average, patients were only receiving oral care 3.9 times per patient per day. Now compared to what the RTs had set as their goal of 6 times per patient per day, that's a big difference. I mean, it's only happening 2/3 of the time that the RTs intend for it to. Now the team knew going into this that oral care was an important part of preventing ventilator-associated pneumonias. So even with this small data set that they were able to collect very quickly, they then had concrete evidence to show that if they were able to improve the number of times that oral care was being performed, maybe they really could decrease the number of ventilator-associated pneumonias that were happening. Finding this concrete data, even on a small scale like this, goes a really long way towards providing motivation to everybody on the team to get behind the changes that you're trying to make. So now, in figuring out how to improve those numbers, the team looked back at the surveys that they provided to the RTs when they asked, hey, what makes it hard to provide this care during the day? The RTs had observed a couple of things. One thing is that they said that they often help nurses with the nurses' jobs, like rolling a patient or repositioning a patient, because they happen to be in the room and they just provide an extra set of hands. So they suggested that maybe the nurses could share some of the work of providing oral hygiene too. I mean, really when you get down to it, providing oral hygiene is a pretty simple task. You don't have to be a trained respiratory therapist to do it. They're trained really intensely on the machines, on the ventilators. But the nurses with very little training, in fact no additional training, could provide oral hygiene. And that way it could be happening more often than if the RTs by themselves are just providing it. They also looked back at the nursing surveys. And again, the nurses had indeed said that the RTs do perform very thorough hygiene whenever they provide it, but that it doesn't happen as often as it seemed like it did. That was in keeping with the hypothesis that the team had made. But the nurses had also observed that they felt like if the RTs didn't bring the oral care supplies with them, they would rarely leave a patient's room to go get supplies from a closet and then come back and perform oral care. Instead, they would just try to return later to perform it when they had the supplies with them, and that wasn't always happening. Now looking back at the fishbone diagram that the team had made earlier in the project, that's one of the things that they had actually postulated that might be a barrier to performing oral hygiene, is that the supplies were just not there and readily available. We've planned our first PDSA cycle. We've done our data collection. We've studied the data we've gathered. Now it's time to act on that data. How can we make changes that will address the problem we've identified? The team started brainstorming things that they could do to address the different aspects of this problem. This is just a partial list of the things that they brainstormed. They thought from a teamwork perspective, they could try to implement ways that physicians could assess whether oral care was being performed every day. They could also train patient care assistants in oral care to try to spread the work around for providing oral care. And that they could mandate that the nurses share responsibility for the oral care with respiratory therapists. They brainstorm ways that reminders might happen to help, remind the nurses and the respiratory therapists to actually provide the oral care as often as they wanted to. For instance, they brainstormed that maybe they could provide some kind of computerized alert for the care team. They also tried to think of ways that they could make oral care easy for the respiratory therapists and nurses to provide. For instance, rather than having the supplies stored only in the stock rooms and in carts outside of each room, that maybe they could have a kit with oral care supplies in each room next to each ventilator. And they could also formalize the process of using chlorhexidine just to make sure that everyone's providing oral care the same way every time in the most effective way possible. After brainstorming those ideas for interventions, it's important to critically assess those ideas and really think hard about how easy they're going to be to implement. Again, you want to do things that are going to not be manpower or time intensive, because that's going to be really hard to maintain over the long term. So training patient care assistants to perform oral care, that's easy. It's not a hard task. It doesn't require a lot of particular expertise. Mandating that nurses share the responsibility, well, that's easy to do as long as you have someone on the team that has some authority to speak with those nurses. That's why it's always really helpful in a quality improvement project to have a multidisciplinary team that involves representatives from all the different parts of patient care. Asking that nurses share in the responsibility of oral care is going to be a lot more likely to succeed if it comes from nurses as part of their improvement team or nursing supervisors as part of that team. Computerized alerts for the care team, while that would be a great thing to do, in reality the team realized that it's going to be actually a really hard thing to implement. Anybody who's tried to have changes made in Epic knows that that could take an act of Congress. So the team decided to abandon that aspect. Placing supplies near the ventilators, well, that's an easy intervention. That seems like, again, really low-hanging fruit. And then formalizing the oral care process, that would just take some training and some information provided to those people providing oral care to make sure everyone's doing it the same way every time. And the team thought that was a feasible intervention. Now that the team had brainstormed some concrete interventions, it was time for PDSA cycle number 2, where they were going to implement just one of those interventions to see if then any of their measures improved. They decided to start with one of the easiest, which was just to put the supplies for oral care at the bedside near the patient. They thought that doing this alone could improve the number of times it happened each day. Now remember, one of the things they wanted to make happen was to get nurses involved in participating in oral care. While they weren't yet going to make a mandate for nurses to participate, they thought that just by putting the supplies near the bedside, it might make it so easy to do that nurses might just start participating on their own. So this is something that they decided to keep track of, even during the second PDSA cycle. We still need to be gathering data during each successive PDSA cycle. We want to quantify, again, the number of oral care kits that are used, but we don't have to do it every single day. They decided to do just 3 days a week, and that would be a representative sample, they felt, of how often it was happening every day. At the end of the week, they decided they would also reassess the respiratory therapist's goals for the number of times they intended to perform oral care to see if that would change with having the supplies easily available. And then finally, again, they weren't yet making the mandate that nurses participate in oral care, but they decided at 2 points during this short period of a month to survey the nurses again to see if their attitudes towards oral care was changing, if they felt like it was easier, if they felt like it was happening more, to just see how another member of the team felt like the intervention was going. So for gathering data, they reused the same check sheet that they had made from their prior PDSA cycle and continued to estimate the number of oral kits used per patient per day. But they updated their approach to counting again because they weren't going to be doing this every day. They were going to be doing it 3 days a week. And it's okay to change your check sheet, your data gathering tool, over the course of the PDSA cycles as your data needs change. They decided they were also going to reuse the RT and RN surveys too, again to reassess the attitudes of the RTs and the RNs and to see what their goals were, and if those goals were changing as the supplies were more easily available. And finally, for each successive PDSA cycle, it's important to make new hypotheses about the data that you're going to gather. They hypothesized that oral hygiene would increase from 4 times per shift to 6 times per shift per patient on average, just by making the oral hygiene supplies easily available. They also predicted that the RT's goals would increase because the supplies were easily available to 7 times per shift. In other words, that's what they would be aiming to do, even if they weren't actually doing it. And then finally, they hypothesized that half of nurses would participate in oral care on a regular basis just because the supplies were easily available. Over the course of several PDSA cycles, including that first month of making the supplies easily available, the MICU team was able to increase the number of times that oral care happened from 4 times per patient per day to 10 times per patient per day. And as we'll see in later lectures, as they analyzed the other data that they were looking at, including ventilator-associated pneumonias, it was able to have a dramatic impact on the number of those ventilator-associated pneumonias that were occurring. Again, all of these things from small, simple, incremental steps that they would take to improve. So in review, each PDSA cycle is one attempt at making a small change, and in fact the first cycle is often just figuring out exactly what change to make. Start with your low-hanging fruit. Figure out which things would be easiest to implement, but that also seem like they would have an impact on your factors that you're measuring, and start making changes on a very small scale so that you can see if they actually do change anything. And finally, make sure that you keep gathering data on every cycle so that you can track your progress. We're going to learn about the tools for gathering your data, as well as how to track and analyze that data over time in the next 2 lectures. But even if you don't know what to do with that data yet, gather it, and we can show you what to do with it. So finally, what now? It's time to get together with your class, get out the process map, fishbone diagram, and driver diagram you've made, and plan your first PDSA cycle. You can start by picking one or more of your secondary drivers from your driver diagram, and use the blank PDSA planning template that's linkable at the end of this lecture to figure out what data you need to gather and how you can get it. Remember, keep your data gathering simple. Keep your surveys simple. Everyone in your team is going to be pressed for time, and the more time intensive you make this data gathering process, the less likely it's going to be that you're going to follow through with it. Thanks for watching. I'll see you next time. And remember, if you have any questions, I'm always available by text, phone, or email.